I'm the Executive Director here at PI. I am excited to be here. Today is my official 7th day workday on the job, but I actually started on the 26th, and I have never been more excited to be in a community than before. This is my first experience with the Guru Project, so I am excited to actually see and hear all of the information that we're going to learn and experience today. Thank you for coming. Welcome to our rooftop terrace, and I hope you enjoy yourselves. I'm going to introduce Nader. Maybe you all know Nader already. He is our executive, chief executive officer. He's something. He's a big wig. He's our CEO, and let him take it from here and enjoy your afternoon.
Thank you.
All right.
Thank you. Thank you. Well, I want to first thank all three of you, Dr. Patel, Richard Taylor, Dr. Taylor, and Dr. Al Power for coming. These actually, Dr. Al Power came from Rochester, right? And it was minus something.
About 10 below when I left yesterday.
And so it was
you're so lucky to be here.
Yes, so there was an 80-degree swing between the coasts. And so I really want to just hand it over to Dr. Patel. So welcome to the Biomedical Convention, which is really trying to help us get some different viewpoints. Exploring the Elephant is our poster. Different viewpoints about what we call forgetfulness, what is often called Alzheimer's and dementia. So, Dr. Patel?
Thank you so much. Hello, everybody. This is kind of an exciting project because we're going to look at all aspects of care, not just the tiniest molecules or the biggest cultures, but kind of everything in between, and how our patients that we care for can benefit by this knowledge that we have. Before I introduce our real two stars here, Dr. Alan Powers and Dr. Richard Taylor, I'm going to give just a brief introduction as to what this Guru Project is about, and in specific this Biomedical Conference. So the Guru Project at AgeSong is essentially about a year-long initiative that really looks at providing total care for patients from where they're at. So we're not looking at a textbook of the way patients are supposed to be, but the patients are our textbook. They're showing us how to look at them. And alongside of that, and this is in part why we're calling this a biomedical conference, and I don't want to say an anti-biomedical conference, but it is true that medications are often the main way that we treat illness. You go to a doctor, they hand you a pill, you feel good, and then you go. At least we hope we feel good. But I think medicine is now evolving to a point where we have to understand that sometimes things have to be taken away as much as they need to be given, or perhaps the changes aren't something that we want to give in a chemical. I want to give you a little brief introduction to who I am. I'm Dr. Richard Patel. I am working a great deal with UCSF over at San Francisco General in psychiatry and neurology, seeing many patients in the ER there, as well as in private practice. I come from a place very different than this world you're sitting in today. Back in the 1980s, which doesn't seem that long ago to me, about 30 years ago when I went to medical school, we looked at little things. I remember my first experience working with geropsychiatry. I was working with the chair of the department there, Alan Grossberg, and he's a great guy, still works a lot with geropsych. And he turned me on to these SSRIs, kind of a new brand of antidepressant that would save the world, and I'm sure we're all perfect because of it. But at the time, it was very exciting. These were new drugs, these little Prozacs and Zolofts and Lexapros and all the things you guys hear about so often. And they really were fantastic little molecules that seemed to help people out without giving them lots of side effects. So we were very excited, and he gave me being an eager third-year medical student, the charge of doing what's called a meta-analysis of these drugs in the elderly population. A meta-analysis is when you look at all the research that's out there, kind of compile it together and distill out important facts about these drugs. And I was able to do that. If I had a little board here, you can imagine my first little circle in the middle of this board, it's going to show a molecule of Prozac. I'm not going to draw it because I have no board, but that's what I was looking at. And I did that article, Depression, or SSR, I can't remember the exact title, a treatment of geriatric depression using SSRI as a comparative meta-analysis, some fancy title like that. It got published. And I got to go to the Neuropsychopharmacology Convention in Puerto Rico and present it, which as a medical student, that's pretty cool. I mean, I was there in my swimsuit and with a little pointer looking at my board, and very exciting, looking at these molecules, and there were hundreds of people there from all over the world looking at these little molecules, and I was so proud of myself, and I went back to Dr. Grossberg, and I told him what happened there, and he said, "Great. Have you seen any patient with geriatric depression or dementia?" And I said, "No, but I did this great article all about these molecules and what other people have said." He goes, "Well, why don't you go see these couple patients and why don't you tell me how you feel these molecules fit in with what you're doing?" And so I saw 2 people with dementia. Now, I don't even remember the type of dementia. Again, we're talking about 50 types of dementia, at least, that are out there. And of course, as many people are in the world, that's really how many types of illness you're going to deal with. So I went to see these 2 people, and let me tell you about them real quick. The first was a very successful in life. He was in his, they were both in their 70s, white, male, tall, kind of athletic built guy. And as soon as I walked in the room, I knew something was wrong. There were clocks, kind of clocks that the staff had put. There was a big clock on the wall, and there was a clock beside him, and he had a huge clock with a huge face on his wrist. And I walked in, and he asked me, "What time is it?" And I said, "Well, it's at 10 after 10, whatever time it was." And he kept repeating that a lot during the stay with him. And he was agitated. He did not feel comfortable in his space. He repeatedly asked, "Who are you?" What I was doing there, what I was taking. There was some paranoia there too. And this person was in a great deal of distress. I'll kind of leave it at that for now. You can kind of get the picture of this guy who in life was very much in control of the situation, very much aware of who people were, what time it was, and what was going on. And his dementing process, which was pretty far along at that point, really caused a great deal of distress. The next hallway over, I met a very charming African-American lady who was, I think, a housewife for most of her life, had a community and a family that really embraced every generation of person that they were with. There were people at home that I learned later that were from multiple generations, and she had some medical problems that made it very difficult for her to stay there, which is why she was in the acute hospital setting. She was lovely. She sat me down and she told me about all sorts of things about her young children, who were actually now grown with children of their own. That didn't matter. She was timeless. She was talking about things as if they were right now. And later in that conversation, I remember asking her, do you want to know what time it was? Because I was so distraught by this last guy. And she threw back her arms and laughed and said, "I don't care what time it is." So these people are both diagnosed with dementia, probably Alzheimer's type, yet their presentations were so very different. And it's hard for me to this day to really say that was due to our little chemical that was on the board here of whatever is going on in their mind. Further along, as I went back to Dr. Grossberg and said, "Well, these are both Alzheimer's, but these are very different presentations, and maybe the different serotonin meds will work differently in these patients," because that's where I was taught. I was taught at the level of the molecule, and then at the level of the nerve and the receptor, where these molecules hit. And then I was, okay, let's look at the tissue, that part of the brain, because the brain's kind of made up of different organs itself that all work together. And then I'm used to the brain. And so that's where I was. And I kind of talked to him, and he was shaking his head saying, "No, you got to look at the person." And that was baffling. This is my first experience in psychiatry. We're looking at a person. But how do I order that on a prescription pad? For this person who's nervous and an accountant versus the person, how do I do that? I slowly came to understand that it's not just about, and you guys all know this already, so you're not naive as I was, but it's not just about chemicals, it's not just about tissues, it's not just about organs, and it's really not just about the person. And that's where I think today we're really going to get some new insights in how to treat people of lots of ilks and lots of illnesses beyond dementia. It's about the person. It's about their family, the people that they make their family. It's about the environment that they're in. It's about the culture that they're in, the culture that they're from, the whole community. On the way here on NPR, they were talking about looking at the treatment of Ebola in children in Western Africa. I don't know if you guys heard this little commercial, just as I did. So they said something that they found that children that had pictures on the walls survived better than children that didn't have pictures on the walls. That was a little tag. I haven't heard the actual discussion yet. But that makes perfect sense, doesn't it? That's an expression of love, and it's an expression of community. It makes us feel more at home and a better sense of well-being. That's what I started to get back in the 80s a little bit. Well, now today, San Francisco is really, in the Bay Area in California, is really a forerunner in the world of this kind of care. We were just talking earlier about maybe taking these messages to Berlin to do a kind of a biomedical guru project out there to other parts of the world to spread this information. And it's because people, especially in the medical community, I admit this, like the security of, here's a pill. Yesterday I was working with a patient who had a lot of difficult problems, long history of anxiety. This is a younger person in her 40s, of anxiety and depression. And her symptoms were evolving, and she was saying, I think I need to change my medicine. So the public is being traumatized. I'm using that word specifically, by being made to believe there's going to be a pill to serve these, to serve the problems they have. And so they come to me and they say, I need a new pill. This person's talking about meaning in life, and I'm going to die anyway. Someday I'll die. Someday nobody will ever mention my name again. You know, my children have to watch me die. What is the purpose of this? I need a new pill. Well, no, this is existential kind of stuff. This is normal, healthy development to be questioning these things at a certain part of your life. But she's asking me for a different pill. So I think part of this biomedical conference is to take away some of the biomedical and do a little bit more of the holistic approach where we have concentric circles looking at all the different realms that we as people live in. Okay, are you guys with me? So let me, again, I love talking about this stuff, but I'm going to try to be quiet and introduce the people who are a couple of the real experts here. Let me start with Dr. Alan Power, if I may, a fantastic gentleman who has braved weather and airplane security lines and everything else.
Lost luggage.
And everything, lost luggage, and who knows what else to make it out here. I could talk for a very long time on just the things he's done to educate the world about dementia and the way that people deserve respect and treatment, but I'm going to say just a little tidbit. And maybe you could take a look at one of his 2 books. I wasn't sure the second one was out, but apparently it is, and congratulations. The initial book was called Dementia Beyond Drugs, Changing the Culture of Care, which is exactly what we're talking about here today. That was back in 2009 or 2010. Won a Book of the Year award from the American Journal of Nursing, not the American Journal of Psychiatry or the American Nursing, who obviously have a really good holistic...
that actually was mailed in because that was my core audience for the...
Oh, is that right? Well, there you go.
To me, that meant a lot.
And it's been, again, there's been lots of awards for this book, a lot of accolades. It's been quoted by lots of people. He has some DVDs out. He's been interviewed. I'll let him speak to him. So, well, we don't need to brag about him too much. He's a bigwig, so ask him good questions. Let's just leave it at that. Our other bigwig here today, I have like 3 pages of notes about things you've done, so let me just... Richard Taylor is a neurologist who developed Alzheimer's himself, probably of the Alzheimer's type, dementia of Alzheimer's type. And as opposed to sitting back, and again, he can speak to this, and kind of sinking into the despair as his family and friends were doing, something in him was able to say, no, I'm going to express this experience to the world and communicate the challenges that it brings up to other people. He wrote a beautiful book called Alzheimer's from the Inside Out. He's been living with dementia for a decade plus, and he's discovered what it's like and the transformation that occurs. And I think he can speak really well to this one little point. As I mentioned, my little silly concentric circle thing where we're looking all the way to family and culture, and don't you see it on the board here? And everything else. The key aspect is it changes. It's wonderful to come from a giving, supportive family and culture that is able to cope with the changes that occur internally with a disease like this. But as you all know, if not, you're going to experience, if you stay in the field, everything changes when you get sick. That caring mother, father, sister, brother, friend may shun you and give reasons. Oh, I'm busy. I don't have time. Because their own state, they can't handle the dysphoria of being around somebody who's changed from who they were. Now, we're all changing in life as time goes on. We all grow into and out of people. Friends come and go and all these kind of things. But I think you see it in a striking way when you come down with such a devastating and, in a lot of ways, poorly understood disease such as dementia. And he's gone through some of this shift, where it's not just your internal state changing, but the world around you treats you differently because of their experience of illness. So we're going to be lucky enough to hear from him a bit, and please do not be shy with questions as we talk today. This is a small enough group. I don't know if there's people around the corner, but please shout if you have questions, and don't be shy, because your input is as important as the stuff that we're outputting here. Without too much further ado, I will also be adding my own 2 cents here and there when questions come up around medications or the medical treatment or the lack thereof. But why don't we start with Dr. Alan Power, and I give the floor to you.
Thanks very much.
Thank you for your attention.
Thank you.
Thank you.
Thanks for the great introduction. Let me just give you a little story about how I got here and what I've been doing since. I'm a medical doctor. I was an internist private practice for several years, and then got lured into the world of nursing home medicine and practiced full-time in nursing homes in Rochester, New York for 2 decades plus. And somewhere along the line, in caring for many, many people who are living with different kinds of changing cognition, I was using a lot of these antipsychotic drugs that are in the news so much because people would become distressed. We wouldn't know what to do. The medical journals would say, try this drug, try that drug. And so, like everybody else, I did. I tell people I wasn't born on a mountain in Tibet where we chanted all day and never used drugs. I'm an internist, and internists prescribe medication. And there are a lot of good medications, but it became clear to me, the more I used these, that they were not doing what I'd hoped they would do. I could often make somebody quieter, but it wasn't the kind of quiet that you or I might feel if we're sitting with a cup of tea, watching the sunrise, or sitting with a child on our lap. It was more like the lights on, but nobody's home. And I didn't really feel that anybody was really living well with these medications, and I was also seeing side effects. So I began speaking out about this, and it's interesting, my book came out in 2010, and the big government initiative came out 2 years later in 2012 to reduce these drugs in nursing homes. But I was going through my files the other day, and I found a grand rounds talk I gave at Rochester General Hospital. It was called Hold the Haldol, Non-Pharmacologic Approaches to Dementia. And this was 1997 I gave this talk. So this was before I really was thinking consciously that there was something wrong. But I was already trying to teach about other approaches. And but it got to the point where there was so much conflict with other people I worked with about, the fact that they felt people needed drugs and I felt they didn't, that I had a lot of trouble explaining why I felt the way I did. And so I eventually sat down and started writing my thoughts because I had to get them straight in my own head. And that's where my first book came from, 5 years ago now, Dementia Beyond Drugs. And I spent a lot of time looking at the data behind these medications for use in people living with Alzheimer's and other forms of dementia. And I found to my surprise that the studies really were not saying very much. And that I thought that there was a lot of groupthink going on among the medical profession about why these drugs are useful. And when I really looked at them, I found that they were not great studies, and we were using a lot of very shoddy data with which to practice. And about the same time I was doing this, more and more studies were coming out about the potential side effects of these medications, and now we know that there are some very dangerous side effects from these. So that's really where the first book came from, and it just happened. The book got a little bit of notice when it first came out, certainly a nice recognition from the American Journal of Nursing. But then 2 years later, when the media started talking about drugging people in nursing homes, all of a sudden I had a book and I became kind of popular because someone had actually written about this and developed a course. And so I basically left my nursing home practice and have been speaking and doing education full time. And when it came time to write a sequel, at least my publisher thought it was time for me to write a sequel, and I didn't really know what to do. I spoke in my first book about the concept of well-being, and Richard used that quote, well-being, and really thought that, all this time what we're doing is, and the biomedical approach is not totally wrong, but it's a concentric circle. It's a narrow view. And what I realized is that we have focused so much on that narrow view that it actually has affected the way we see people and the way we support them or try to care for them and the whole kind of system we've created to provide care and support for people. And with that comes a lot of fear, a lot of stigma, and a lot of blaming things on disease, when instead it may be the environment or the way we're interacting with people that is really contributing to that. And I realized somewhere along the line when I met people like Richard, Christine Bryden from Australia, Ed, who's in the room here, who had other perspectives, that the perspective of the person living with the condition was critically important and was mostly being ignored by my profession, because after all, they're confused. We can't pay attention to them. And I realized that the more I actually tried to understand the person's perspective, how they were experiencing the world, the more insight I was getting that I'd never been taught before. So I started early on to redefine dementia, and I define it very simply as a shift in the way a person experiences the world around her or him. And I just keep it very simple because there's no stigma, no judgment attached. It also relates to something that's happened to everybody in this room. As Richard said, our perspectives change as we get older. They may not change the same way or maybe as quickly, but when you understand that it's possible to see the world differently, it connects you, and you start to look through people's eyes and try to understand what they're experiencing a little bit better. And so it's a definition that connects us, whereas most medical definitions of dementia separate us. They put people in a box, or 50 boxes, and say they have a disease, we don't understand them. And that's what leads you to old ways of doing things and really blocks you from coming up with new ideas. So I realized that this was a deficit-based approach that just looked at what was broken, what was wrong, and trying to fix things that may or may not be able to be fixed, instead of working on what are those strengths, what are those abilities, what are the things people need that even if they can't remember what they used to or do what they used to, are still critical to every human being. And that's where I went back to this model of well-being. And there are a million different models of well-being, but I chose one that had 7 dimensions of well-being, which are identity, connectedness, security, autonomy, meaning, growth, and joy. And I borrowed that model, switched them around, made a little Maslow-type pyramid out of them, and wrote a second book based on looking at this whole experience of changing cognitive ability through the lens of those 7 aspects of well-being. What does this do with your identity? What does our care system do to your identity? What does our care system do to your connectedness? If you have a different person bathing you every week, what does that do with your feeling of relationship, with your feeling of security or autonomy or dignity? And it gave me a lot of insights I'd never had before. I thought it would be a little addendum to my first book, and it turned out being 40 pages longer than the first book. So that is really where I've been going, and I've come up with ways of understanding people's distress that looks through the lens of well-being and what might be missing in those domains of well-being, and how can we work proactively to actually restore those aspects of well-being rather than just trying to intervene for the moment, either with a pill or with some other intervention, which frankly, even if it's just a hand massage, that's not the solution. Because if the person is missing autonomy in their life, sitting with them and playing music or giving them a hand massage is not going to change their life. So it has to go much deeper than the typical non-pharmacologic intervention that we all learn about, and really get into this idea of what does the person need to have a full life, and how can we help restore that as much as possible. So I'm going to stop there because I do consider myself a professional student of dementia, and I consider the true experts the people who actually have lived with a diagnosis of one or more types. And I have my good friend next to me who's the voice of experience. And so I'm going to stop gabbing for a moment, turn over to Richard, and let him tell you what it's really about, at least from one person's perspective.
My name is Richard, and I've been living with the symptoms of dementia and a diagnosis of Alzheimer's, probable Alzheimer's, for almost 10 years now. When I was first diagnosed, I did what most people with Alzheimer's diagnoses do, and I started to pull into myself. And it was easy because people were pulling away from me at the same time, so we just kind of disengaged with each other. And I didn't know anything about dementia. I'm a psychologist, and as all the psychologists in the room know, we know just about everything there is to know. Since we're psychologists, at least that's what my chairman told me when I got my degree. And if we're clinical psychologists, we've heard it all. But I didn't know anything about dementia. But after the doctor told my wife and my brother and I that I had dementia, probably the Alzheimer's types, We drove home in silence, and as I got out of the car, I started to cry. Hysterically, I started to cry. And I had no idea why the hell I was crying, because I didn't know anything about it. So, like a good academician, I Googled it and found 1 million pages. I swallowed as many of those as I could. I passed them. And after I passed them, I ended up with a pile of more questions than when I started. Because there are no answers to the way we approach dementia. As long as we're convinced that it's a disease, and the answers to all the answers to it are within the medical model, we'll never help people to the extent that they need to be enabled and re-abled. I think most people who live with dementia are being disabled. We're looked at by our deficits rather than our strength. We're defined by what we can't do rather than by what we can do. People don't take time to find out what we can do because they're so worried about what we can't do. And that's really what their job description is. Make sure they can get everything done that needs to be done. So we are systematically taught to be impotent. At the same time, when we are struggling with our own sense of impotence because of stigmas, and at the same time, when we are struggling with the fact that our brains seem to be becoming impotent, and that we cannot deal with the world the way we used to deal with it. We cannot recall the details of the world the way the rest of the world recalls them. We cannot manipulate information easily. So we're stuck in your world, and your world just doesn't work for us. You know, you can close your eyes and say, well, this is what it's like to be blind. You can get in a wheelchair and lock yourself into it for a day and have some sense of being in a wheelchair. But you can't get in a dementia machine and figure out what it's like to have dementia. You can't be a dementia what did they call that?
Empathic?
An empathic.
Yeah. Oh, you're talking about Star Trek?
Yeah.
Star Trek.
Counselor Troy, wasn't that her name?
Yeah.
Yeah, you
She's in all the CrossFit
can't
poses.
be an empathic. You can only approximate that. And as you said, there are many people who have never even dealt with people who have dementia who honestly believe they're empathic to that. But they're empathic, for instance, in their own language. One of the things that struck me, what you said, was there was paranoid there. I would say there was fear there, because that's what motivates most verbal behavior for people with dementia is fear, because they can't understand exactly how the world is working. They know that, and they know that you know that. And they can see the pity in your face. They can hear the sadness in your voice. They don't have the connection to you that they used to have in just normal relationships with people. So you use your language and you say, well, he's paranoid because he asks a lot of questions. And he asks the same question over and over again. Why am I here? Why am I here? What's going on? To me, that's his brain speaking, and it's saying, what the hell's going on here, you know? I could figure it out for a second or a minute, but then I get it wrong again. My family went through a period where when I would ask the same question more than once, they would tell me how many times I'd ask it. You know, well, that's the third time you've asked that. Now, they did that lovingly. They wanted me to know that that's what was happening. I would say to them, well, to me, it's the first time that I ask you this question. I don't repeat this question just to piss you off. I repeat this question because I want the answer, and I can't hold it in my short-term memory the way I used to be able to hold it. I think looking at the medical model is just the wrong way, damn it, to look at people who have dementia. It's a cognitive problem, and it's a cognitive problem that medicine just has never addressed. Psychiatry really has never addressed it, except when there was acting out behavior and they wanted to extinguish some behavior that was socially inappropriate or self-destructive for the person. And we're just now, through brain science, beginning to figure out how the brain works. We haven't figured out how the brain doesn't work yet, because we haven't figured out how the hell it works now. There's a language of thought that's running in our brain. I think of it as a ticker tape. It's always running. That doesn't stop running when I have dementia. I think it actually runs faster because we're more worried. We have more things to think about, to figure out, be it on a conscious level or on a subconscious level. It's why people with dementia sleep a lot, I think, because we burn a lot of energy. But it's intellectual energy. It's the brain. It's running full all the time because our basic needs, as our symptoms increase, our basic needs are not diminishing. And people see that inverse relationship, I believe. The worse or the stronger our needs are, the stronger our symptoms are, the weaker people assume our needs are. And what happens is then their needs become our needs. Well, what you need to do, Richard, is calm down. Yeah, but I feel anxious. I don't know what's going on. Just calm down. Don't worry about it. We'll take care of it. Brains don't accept that kind of BS. They know that that's BS. A brain just can't give up and say, oh, well, I got dementia. I guess I'll just roll over and slide down the hill. A brain is always trying to figure things out. A brain is always trying to be rational. A brain is always trying to understand who I am, where am I now, and what's going on. Now, difficult as that to do, it's easier to do that if you have the ability to recall memories or reconstruct memories. We have a popular belief that memories are like kernels of popcorn, and you just go and heat one up and it pops and there's the whole memory. And then the memory goes away and it goes back to being a kernel again. That's not the way memory works. That's the way we thought it worked, but it doesn't work that way. It creates the situation, it recreates the situation every time you think of it. Well, if every time you think of it, your brain is less able to cope with all that information and make the same decisions that it's been making for 50 years, no wonder it's so difficult for us to get along in the world. So I'm here to witness to people, first of all, that people with dementia are still whole human beings. We never lose our need for self-esteem, but think of the things that we go through in nursing homes and Alzheimer's units. If we had our wits about us, if it was you living there, what would happen to your self-esteem if you were in one of those? If people always spoke loud to you, if your elbow needed more help all the time wherever you went, if every time people spoke to you they knelt down and looked you in the eye and smiled at you. Now those are all things that you do to try to adapt to us. I'm of the belief that if you would just see us as human beings, as whole people, as not diminished in our humanity, all these other things would just fall to the side. We don't need to be trained in how to talk to people with dementia if we saw them as whole people. But now we go to, let's learn the nonverbals of how to communicate with people with dementia, and let's get on their eye level, and let's hold their hand and pat their hand. all of those make assumptions about the individuals that I believe personally are not true. Now, part of this is my own fear. I fear that as I sink farther into dementia, I will end up in my own prison, a world in which I live in two worlds, the world of my brain right now and the world of my brain as it was. And I'm always struggling. You just can't turn off figuring out, why the hell am I here? What's going on? Is a tiger going to eat me? Where's my next meal going to come from? Who are you? So what happens is you develop a relationship with me. You know who I am. You read the 200 questions my family filled out in this brochure that I had to do before I came here. You know me, and you develop a relationship with me. I can't remember what your name is from one day to another. I don't know who wakes me up. I can't tell the staff from the visitors. But you assume, because you're developing a relationship with me, that I'm developing a relationship with you. Whereas the difficulty I'm having is just in understanding relationships and holding on to them. It has nothing to do with you. It has to do with what's happening in my brain. And I believe we don't understand that enough. And the medical model says, well, if you don't understand it, we got a pill for it. We don't know why the hell the pills work. Lots of depression pills work, we know, but we don't know why. They just work, but they don't work on everybody. They work on somebody. Well, I think we have to stop all this and say, wait a minute, we're all human beings. We all have the same needs. We're all trying to communicate with each other. We all need to understand what's going on today. And I've got some problems with that. I admit that. But my problems are made worse by the fact that you see it as a problem rather than as a difference. And you have differences too. It's why you get divorced, for heaven's sakes. But we learn that once you get divorced, we start treating you the same way after the divorce. Once you get the diagnosis of dementia, we never stop treating you differently. And in fact, we're always looking on how we should change relating to you, because you're getting sicker, you're fading away. And now the trend is to say you're dying. A national organization said everybody who has Alzheimer's is going to die. Well, the news is everybody's going to die, you know? Now we're, 10 years ago, nobody died of Alzheimer's. Now we're the 4th, 5th, or 6th leading cause of death. Now, has Alzheimer's gotten more deadly? Or have we shifted our perception and saying, well, you're dying, you know, so when you're dead, it must be because you had Alzheimer's. That's what's happening. We're going in the wrong direction. It isn't just a matter of getting rid of psychotropic drugs. It isn't just a matter of understanding why problem behaviors are problem behaviors. It's understanding who we are. And I think if you understood who we are, all this other stuff would kind of fall away. Everyone would say, gee, I'm embarrassed. I used to go to a whole week conference on controlling problem behaviors, when if I just understood what your problems were and I accepted those behaviors, I wouldn't need all this training. So that's who I am, and that's where I am right now. I'm running as fast as I can from my future. I know what my future is, and I hope by the time I get into that future that you all will be sufficiently enlightened that I will never be in a chair mute and someone comes in and says, oh, there's Richard Taylor, look. And somebody else says, oh no, that's not Richard, he's gone. He's just a shell of himself. And we actually say that about people with dementia. They're just a shell of themselves. Hell no, they're always all themselves. You just don't know them. And you're not making any effort to understand us. You're more interested in your own agendas of controlling our problem behaviors and making us seem happy, when you know in your heart of hearts we're not. When you know in your heart of hearts what you're doing is meeting your own needs, and to some extent, in some few cases, our needs. But it's mostly a projection of your own needs onto us because you don't think we have any needs. So it's easy to project them onto us. So that's my story, and I'm sticking to it.
I often talk about I often talk about a person whose legs become paralyzed who's in a wheelchair who comes to a stairway. The person who comes to a stairway in a wheelchair doesn't need to be told, get up and walk up the stairs like we do, and they definitely don't need an antipsychotic drug if they get up and fall. They need a ramp. And so in a similar way, a person living with the symptoms of Alzheimer's or other kinds of changing cognition needs a world where they have ramps, cognitive ramps, to continue to associate and to continue to succeed. And I think that that's where we get it wrong, because whether it's home or a nursing home, we build and maintain living environments based on our view of the world, our needs, our schedules, and we expect the person with the changing mind to fit. And when they don't, then we give it a label and we give it a medication. And once again, as Richard says, and when I did my pyramid of the 7 domains of well-being, I have identity and connectedness on the bottom. Because if you don't know the person and have a relationship with them, there's no way you can fulfill any of the other well-being needs. You can't make someone feel safe or in control, to give them, the ability to choose if you don't know them or have a relationship. And I think that points it up.
I could say a couple words. Okay, so lots of wisdom here, but you guys are going to get dirty with this. This is not going to be a safe lecture. I remember, that's why I'm taking off my jacket, because I'm really serious now. I remember back at Stanford in the 90s, so you get ready here. So in the 90s, we've now moved from the 80s, we're now in the 90s, I'm in my residency down at Stanford, and I'm seeing a patient with behavioral issues on the inpatient ward, a person with dementia who needs something, so I pull out my magic pill and I give them Haldol. The nursing staff is so happy. The patient is quiet, seems no real complaints, but like you're describing, just not quite there. But everybody else seems to be more happy that the person's not wandering into other patients' rooms and making people upset. I come in to visit this patient on what I thought was my last day of consulting. I wasn't the main caregiver, I was just a consultant. And the family is there, and they're in tears. And they said, "What happened to our father?" And I said, "Well, he's right here. He's fine. He's comfortable. Nothing really is happening. Things are stable. Hopefully we'll discharge you guys home soon. Here's the medication." They said, "No, this is not our father. There's something going on." They were in a great deal of distress. And I quickly excused myself, having no clue what to do, because although I went beyond the molecule and I went beyond the tissue and I went beyond the brain, I was looking at the whole person. I really wasn't looking at the whole person. I certainly wasn't looking at the family. I certainly wasn't looking at the community. So I said, "Thanks for visiting, I'll see you later," and scampered off to my supervisor, who promptly listened to this story. I was nearly in tears. I felt so bad not being able to help this person. Well, I thought I helped the person, but in fact, I didn't really. I just quieted the behavior. But I started getting a little tearful. My supervisor took off his jacket, put it down, and said, "You didn't think you'd treat these people without getting a little dirty yourself, didn't you?" And I think that's really true. And I have to say something that I bet most of you have experienced a little bit by listening to the introductions. Was there any time that any of you felt a little uncomfortable with the descriptions or a little afraid listening to what Alan and Richard were talking about? I'll start. Okay, so I'm beyond pills, right? I'm so well adapted to this holistic method of care that I know that I can hold somebody's hand and that'll be wonderful. Look at what a good job I'm doing. Well, what did he just say? He just said that, thank you. He just said that wasn't enough. Wait a second. Well, I have pills. I can nod and be compassionate and hold hands. What do you mean that's not enough? Did anybody else feel like a momentary kind of fear? You're nodding your head. Okay? that's important to notice. I think when we start feeling that stuff around people, around these narratives, that's when we're getting to something a little bit more real. Until then, I'm distancing myself with pills. Hand holding's a little closer, but I can still, assure myself that I'm doing some good. And then I leave that hand, that person has no clue who I am, and then I walk off to the next person who I hold their hand and take their temperature and listen to their heart. So I'd like you, if there's anybody who's brave enough to kind of share what kind of struck them that didn't feel comfortable, because we're all used to models of care. I love the 7 things. That gives me something to write down, and I can bring on my chart to a patient and write down 7 little things I should be checking on. Once again, I'm putting up a little wall. Is this kind of making sense?
Oh, yeah.
Between myself and the experience of the other person. Whenever you hear somebody speak in this manner about treatment, and there's a little bit of a nervousness or a fear or something that doesn't feel comfortable, that's where the money is. So I just wanted to comment on that, because I think some of the comments that Alan mentioned certainly stirred that up with me.
And I would say, just very quickly, that the reason I make those comments is not just to provoke, although that's certainly part of the process, but because these are things that I struggle with, and so I came to a different level of understanding. But I had that same thing, and I spoke for years about the so-called non-pharmacologic interventions, but I had to confront with myself in my nursing home practice that I would sit down with the staff and we'd come up with this laundry list of things to do, which sometimes included laundry, and they would calm somebody for a short term, but I'd be back at the med card again a week later looking for maybe Depakote or maybe an SSRI or something that wasn't an antipsychotic, and so I had to challenge myself and say, the pills are bad. Why isn't this stuff that should working? And I realized that it really went deeper than that. And just a quick story I tell in my new book that I tell a lot, and this really showed that this is what gave me the light bulb moment. I think 4 or 5 years ago, I was speaking in a rural section of Iowa for the local Alzheimer's chapter, and some people who worked in assisted living told me about a gentleman who moved in and almost immediately started trying to exit the back door. And of course, they would redirect him, and they would have this laundry list of things to engage him in. And the more they redirected him, the more insistent he became. And finally, one day they were talking to the manager, and the manager said, well, you know what, we have a fence back there. It's a nice day. Why don't you just let him go once and see what happens? So they stood back. He went outside. He went to the back fence, and there was a herd of cows in a pasture. And he stood there and he watched the cows for about 15 minutes, and he came back inside and sat down, and he was fine all day. And they mentioned this to the family, and they said, well, he was a farmer. Every day he would check on the cows. And so the reason I tell the story is it's not just that they figured something out that was clever, but what do we do when we see someone trying to exit the door? We give him a hand massage, we get some music going. Maybe he wants to check the cows. And until you know that about the person, none of those other interventions are going to work. And that's why the studies of non-pharmacologic interventions are not more positive, because you got a researcher who says, I'm going to try lemon balm aromatherapy because it's calming. And they pick 30 people at random and give them their intervention at a time they choose, and then they're flabbergasted when everybody doesn't get better, or when they get better for a half hour and then are distressed again 3 hours later. So once again, it goes back to what the expert said here. When you know the person in an historical context, and know who they were, but also who they're becoming, because it's not always the same as who they were, and try to navigate that, then you begin to get some insights that maybe you don't have before. And that really helped me to understand that in a way I never did before.
I would say it goes beyond knowing. It's when you appreciate the person as yourself, is essentially what I guess I'm asking people to do. Love them as you love yourself. See that as just as necessary for them as it is for you.
There's a writer named David Everson from Australia who's written some great papers about knowing the person, and he made a very powerful comment in a paper where he said, if you really believe the person is going away, then what happens to your ethical obligation to give that person humane care? If there's not a person there anymore, you kind of lose that obligation. And I'm not saying that there's abuse all over society, but in little ways, we give people a little bit less than we would ever want for ourselves because we have a little lower expectation. So we say, it doesn't matter if a stranger gives him a bath every week, he doesn't know their name, or don't invite her to the care plan, she doesn't know what's going on anyway. Or in the case of, I met Sally Magnuson, the BBC reporter who came to interview me, and she did a book about her mother's journey with Alzheimer's, and in doing so she interviewed a woman whose father lived at home with home health care support, and in the course of a year he had 106 different home health workers come to his house to provide care. Now, none of us would ever stand for that. A stranger walking every day trying to reacquaint themselves with our needs. And yet this organization thought that this was an okay way to practice because it met their needs. It was agency-centered. It wasn't person-centered the way we like to talk about. So absolutely, no, appreciating the person. I love Richard's challenge that he's a whole person. And I remember Richard saying once when we spoke in Minnesota, if I had a stroke and my arm didn't work anymore, you wouldn't say, oh, Richard's gone, he's not there anymore. Or, if you have an amputation, you wouldn't say, well, no, Richard's not there anymore. And yet when your brain changes, all of a sudden, the person disappears. There's no reason for that. It's our perception, and it's our ability to communicate and connect that is affected. And so we, maybe as a defense, say, well, I can't connect, so there must be nothing to connect with.
Well, this is actually, what you were saying was very much touching me, that we come from a place of wanting to control and impose our own ideas on what is normal and how you should behave. And that, of course, feels so true, right? Because in some ways, that's that's what I would like to do. I mean, I like to be in control, and I like to adjust you to how I would like you to be. So in some ways, the Guru Project actually wants us to stay curious in what you have to say, because maybe there's something that we don't understand, right? So that's the idea then. How can we keep up curiosity? That's what you're asking, Richard, right?
Yes.
Stay curious.
And
Do you have a? Oh, I saw your hand go up.
I was having some resonance around having been told. My sister was born when I was 10. She was profoundly Down syndrome, and all my growing up life, I was told she doesn't know any different. She doesn't know any different, and that was just a wound to me. That was really a deep wound, and I'm thinking that part of the reason I felt a little bit of that wound when I heard you say, if I was coming from I thought I was coming from an empathic place, but I was using my language and I wasn't really connecting with you. And I guess what strikes me is that we are poor. We have a poverty already in being able to connect with each other, and whether, for whatever reasons, whatever ages we're talking about, I hate to talk about as a society, but so I guess the challenge is to learn from zero sometimes to connect. We're poor.
well, and we'll always be poor. Thank God there's people who are poorer than us, because that makes us feel rich.
Yeah.
In a way, it can be a gift of Alzheimer's to maybe help us learn better ways to reconnect when we've got such an impoverished society in that way. That's the way to look at it. Yes, ma'am?
Just one thing that really struck me was when you were talking about the shower situation, and I've noticed just working in the industry that always seems like a challenge. Caregivers relating to residents and whatnot. And I was with one thing about our particular caregivers is we like to have our residents look well kept. And so there was a particular resident, she had a stain on her shirt, so we went in and we wanted to change her shirt. And she was very uncomfortable with that I noticed, seems like she was very uncomfortable. She hurried up, took the shirt off and put it back on. And doesn't that make sense? If you don't know someone, why would you feel comfortable
having them take off your
right? And
clothes,
further than that, having them shower you in your most intimate body parts, right? That was just kind of like a moment to me, like, duh, I don't know this person. Why would they?
And let me just ask this question: how many of you? I'm assuming everybody in here is a good person. You all look like really good people, the kind of people I would want to be friends with. How many of you is ready to turn to the person next to you and have that person strip you naked and give you a bath? And we ask people in our care. Don't answer. There's one in every crowd. There's one in every crowd.
Maybe a couple, yeah.
I suppose if I were sitting next to Penelope Cruz, I wouldn't need to ask that question. But yeah.
Well, I mean, caregivers giving you a shower, but my husband has dementia, and up to 6 months or so ago, he was fine with getting into the shower, taking off his clothes, or having me help him get in the shower, and I would, shower. Just a few months ago, he just was totally resistant, and was getting worse and worse. His resistance just did not, from embarrassment, I think, because he's becoming incontinent or whatever. But so about a week ago, his thing is always why? Well, I can try to explain, but it wasn't. And well, why did you shower first? And so I called him on it. I said, okay, I'm in here. And we've been showering together ever since. And it's a logical, and doesn't work maybe in a long-term care facility. But even for me, I had thought of it before, but I thought this could be incredibly dangerous if he still continues to resist. We're both wet, slick, and in a bathtub in a confined space. But it didn't. I mean, he's loving just, and I can do anything, as far as cleaning him up. I probably could use, a brush or something, and it's working for now. I'm not saying it will continue to work, but so I don't know what the answer is.
So it takes
even with having a long relationship, the person will resist getting naked and getting showered and stuff.
It takes getting outside the box. It takes a little risk sometimes. We all have to take some risks, and we have to understand that risk is part of life too. I don't think it's so much a matter of because you have been in a relationship that it would be awkward for him. I still think it's that power dynamic. It's that idea of I'm a man, and this person who I love and is supposed to care for has to do for me. And that's a real tough thing. I mean, that's my personal guess about what might be behind it, more than just that he doesn't recognize you or that he feels embarrassed to be naked.
He recognizes me.
It's that whole idea. And as much as we care for people, our tendency to do for people creates a power dynamic that basically says, I have to do for you because you can't do for yourself. Before I believe you had your hand up, so I didn't want to cut you off.
One of the things that I was thinking of that kind of made me hitch up some is the struggle that I have with our tendency, my tendency to be task focused. When, especially I'm in an agency, I'm working with and for other people. The so-and-so has this issue, and so I want to focus way in, find out what's that issue, what do I need to do with that. And I was thinking of how, industry-wide, across medical, general caregiving, psychological, we all have that sort of thing like this one thing I'm going to do is going to be that magic bullet. I really, really hope it is. And it comes from a great place, but in that way we lose exactly what you were talking about, which is the multidimensionality of the person in their situation. And it's very easy for us to do in the course of, an hour, an 8-hour day, a 40-hour week, to get caught in that cycle rather than sort of staying present with ourselves and also holding the anxiety of this may alleviate one thing, maybe, but it may not touch anything else. So I may have to keep sort of being in this cycle of not knowing and not being able to do enough, and just being able to be present and be as helpful as I can be with it and to do the best I can to relate with this person. And
that's the world they live in.
Exactly.
You're just saying, well, you can't break out of your brain, but I can approximate where your brain is, and I can develop a relationship with you.
I think all of us from the outside sometimes have that hope, and it is a fallacious hope. I can't understand what the process is. It's just sort of like, wait, where can I hope to connect? Where can I give something?
As I walk through assisted living communities, Alzheimer's communities, I see that there's a relationship that the staff has with the people. They do, they love them, they like them, they're part of their family. That's why people stay and don't get paid much and don't get reinforced much by management, but some of them stay for 20 years. But what happens is they're imposing their motherly, sisterly, daughterly, aunt, whatever it is, on a person who's not even aware that it's happening, but it has a debilitating effect on them because it limits their ability to express themselves. And we pay the big bucks to go to your places rather than to go to the Holiday Inn, because at the Holiday Inn, if I stayed there forever, everybody know my name, everybody know what my wants and dislikes were, they give me a hand once in a while. I'm going to professionals who I hope I'm laying my psyche in your hands. I'm laying my ability, my humanity in your hands. Now do something with it. Help me, enable me, because everybody else disables me. And I think most people with dementia first need to be enabled because they've been trained to be helpless. They've been afraid to speak out. They've gotten embarrassed sometimes with their symptoms. So they just pull more and more into themselves. And you just can't say, all right, now I've been born again and I'm going to have a different relationship with you. You have to understand we have to be re-abled, I think.
There's a couple pieces of this that I want to talk about, because this is impossible to do. You can't have 20 patients you need to see and know intimately who they are. It's an impossible task, right? And also, you're right, we go in as fathers, as mothers, as sons, as helpers, as doctors, as nurses, as psychologists, as everything. And that's what we bring to the table to treat people. But people are not individuals in the way they live their life for the most part. We are part of a family, we're part of a community, and it's the same way with healthcare. So when I'm seeing 20 people over in the San Francisco General Psych ER during a busy day, I know I am not going to be present 100% to see all aspects of their care. Their bio, psycho, social, spiritual. That model might sound really good, what we're talking about today, but I know it is physically, mentally, spiritually impossible for me to be present for all 20 of those patients. But I don't have to be, because I work with a team. And that's really important. Because when your team member comes to, for example, somebody downstairs comes to me and says, Mr. Jones fights me every time I try to give him a bath. And so I have to get extra help to hold him there while we're scrubbing him and he's screaming. We don't know what to do. That's fantastic. These people are working with me. In that moment, they're probably doing the best they can do. They hold them, they need to bathe them, they need to take care of whatever they need to take care of. But the reality is they can't do all aspects of the care themselves. So they call me, they talk to other members of the staff to say, what do we do? Now, I can't physically hold somebody and wash them during my day, so they're doing something I can't do. And so luckily we have to be humble enough to listen to all those other people that are around us. Because one person's going to be a mom, one person's going to be the chef, one person's going to be the bather, one person's going to be the medicine man, one person's going to be that. And so as we speak, part of the distress that comes up is the feeling of, oh my God, I only have so many hours in a day. How can I sit with somebody and learn everything about them? The truth is, you really can't. You're not expected to. But I'm sure in your case, you need some help too. I mean, you're there really helping your husband, but even in somebody with that intimacy, you probably need other people to help you out too. So this isn't really, as you listen, something we're supposed to take on individually. We are together the community that we're trying to build that supports these people. And I just say this because I know as I'm listening, I'm thinking, I can't do this. Because I can't by myself. But with everybody else on board, they know that they're watching my back, I'm watching theirs. They ask me about showers, I ask them. So I think you have to listen in a way that doesn't expect you to carry the entire burden. Because otherwise it's easy to tune out and give up. So I just wanted to kind of throw in those little
comments.
comments.
I think it's a great point. And the thing that reminds me of is the reason why I really tied a lot of what I talk about into this whole nursing home culture change movement, the idea of transforming the way different elder living environments operate, changing them from institutions into more homes or communities for people to live in, because part of the barrier is this hierarchy that says, I'm the doctor, And the person who's a nursing assistant doesn't have authority to give me useful information. And if you work in that kind of system, you will never find the answers. And I got to be a bit of a stickler in my days at St. John's Home. I actually got to the point where, because they would always set up the care plans around the doctor's availability. And if I got there and the nursing assistant wasn't in the room, I would say, I'm not starting this meeting until you get that person, because they know a lot more about this person than I do. And the family always wanted to hear what the doctor had to say, but the person that spends 4 hours a day with that person always had information. You know, when that person was invited to speak and join in the meeting, even though there was a nurse manager and a social worker and a rec therapist, doctor, that person had information that nobody else in the room had ever known. And so this really takes a very radical, I mean, once again, this is part of that biomedical. Biomedical says, you know, the doctor is, you know, God wears a white coat because sometimes he thinks he's a doctor or something like that. You know? and it says, you know what, we're not the most important person in the room. We have a skill. But as Richard says, we're part of a team that has varied skills, and unless you can really tap into all that expertise, then you're not really going to be successful. And that's how we got into pills, because everybody went to the doctor. You solved this problem. And there's only one thing I have that nobody else here has. That's a license to prescribe pills. Richard, now, you know. So if you come to me saying we need something, you're saying give me a pill, because if it was anything else, you would have done it yourself. You wouldn't have come to me. Sally, do you have your hand up?
Yes. I like the idea of participation, and I think the participation should be the individual who you're talking about, and I think that it should be everybody giving their own feelings about something, not just looking at the person and talking about the person all the time. I hate when we say he, and he is sitting right next to me. And as a engagement regional director at AgeSong, engagement and education, which is basically like the activity coordinator, we're often expected to have a lot of activities on the calendar, scheduled activities, because that makes us look like we're doing something. But the truth is, what's really important, and Al, you had said this, is real engagement. So for me, an activity could be, well, let's see, Nader wants us to have more book reviews of some of the books that we produce. Let's get my folks around me, you know, to help do these book reviews, and let's plan it together. Or for me, an activity is, oh, holidays coming up, I'm not going to sit in the back room and plan it with a couple other colleagues. I'm going to plan it with the people for whom the activity is for. So we all plan it together. And so maybe that person, one of the people, is just sort of hanging out and sleeping. But how many times have any of us been in a meeting and sort of hung out?
Hopefully not today.
I mean, to me, the tone of the voice, of your voice, is engagement. If somebody doesn't understand anything I'm saying, it doesn't make any difference, because they know more than I do anyway. You know, sorry, you don't get that one. Okay, you got it. Yeah. So anyway, I wanted to put that out. You know what real engagement is.
You know, once a day or twice a day, you staff everyone in your facility, and you say what's their temperature, what's their blood pressure, how their bowels move, and why don't you staff the psychosocial needs of people first? Because the predominant reason that person is there is not because of their bowels or their temperature. They're there because they have a thought disorder. How often do you talk about how that's impacting that person's quality of life? What models do you use to run that kind of staffing? When you say we have a team, you would staff the team. Why isn't that the #1 priority every day in every community with elders in it? Let's staff their psychosocial needs. Let's take Al's or Abraham Maslow's or whatever model you choose to understand human beings, and give them the credit for being a rightful owner of everything in that model. And then the challenge for you is, well, what can you do when you give Richard a bath to help with his self-esteem? What can you do when you eat dinner? Now let's talk with them. Let's talk about that tomorrow and see what kind of progress we make.
It's yeah, you know, doing this along with tasks is not another job. It's doing your job differently, basically. It's the engagement that happens. It's the connection before you start a task. All those things that don't really add hours to your day, but they actually make for much better engagement and interaction. I even had somebody recently ask me, well, what about if somebody assaults somebody? How about if somebody actually punches somebody? You know, are you saying we shouldn't do something medically about that? And I say, listen, we have assaults in our community. We have spousal abuse. We have bullying. We have people that hurt people in fraternity hazing. In which of those circumstances would an antipsychotic be the proper way to respond to that person? So why does dementia be, you know, suggested? Well, because we see this disease, and when we see disease, we think pill. So if a guy holds me up down the street at the ATM, nobody would ever give him Seroquel. But because Richard's got diagnosed of Alzheimer's, if I do something that upsets him and he swings at me, he's got to be medicated. It makes really no sense, because actually if you look at the chemicals, the chemical changes in Alzheimer's, there's really no rationale for these drugs. They block a drug, they block a chemical that is not elevated, as it is in schizophrenia. It's actually depressed in most people. And that's why you get more side effects than good effects, because there's never been really a good reason to use these pills, except that they quiet people, and that's mainly sedation.
Quick comment.
Yeah.
Because just
I
to
wanna
be
hear from
devil's
the
advocate,
psychiatrist.
here I come.
Because I'm pushing.
I don't have anything else to take
I'm pushing you over here, so I want to hear it.
What we're treating at some time isn't necessarily the individual.
Yeah.
We're treating the environment.
Yeah.
Right.
You know, patients get stuck in a place that's conducive to get me out of here, and we often don't have a lot of tools, time, wisdom to figure out another manner to fit the person into the community that they're in.
Agree with that 100%.
And so it does take a lot of time and effort. And here's an idea. Whenever new interns or students come in to evaluate people with dementia, they should sit with them, they should have a conversation, they should go back to the supervisor and recognize where their discomfort is. Because that's what we end up treating the other person for. So our own discomfort, and believe me, if somebody takes a swing at me, I want to medicate them, because you know that's the tool I have besides running out the door. And that doesn't, neither one maybe help, but it's my quick, you know, reaction to the fear that I have to give the other person a pill. So the more that we can take the temperature of ourselves and see what's bringing on those feelings, the more we're able to go to the treatment team and say, when I was sitting with Mr. Jones, this fictitious demented person that I've mentioned before, I started getting scared when his fists went like this. And they may ask me, well, what happened right before? What happened after? How was, and you can actually start to get to the heart of what you can do for the patient as opposed to what you can do for yourself. And I think that's what happens is we give patients pills to help our own fears.
I just mentioned 2 recent studies of people that do strike out during care showed that we talked about rotating staff and being unfamiliar. 2 studies showed that one of the major factors in predicting those kinds of reactions was the depth of relationship the person had with the person providing the care. So people that rotate staff members are asking for them to get beat up because they are actually creating these situations, as someone was saying, where a stranger is providing very intimate care instead of, and once again, you don't always remember someone's name, you can't always pull that up, but there are many kinds of memory. You know, there's the explicit memory, there's implicit memory, like remembering to lift my foot when I go over a curb. And then there's emotional memory too, where I don't know your name, but I remember the sum of our interactions and whether you made me feel good or made me feel bad. And my personal bit of advice is, if someone is fighting you and you're giving them a bath, don't bring 3 more people and hold them down to complete the task. As Joanne Rader says, no one ever died from not having a bath. But you will give them an indelible emotional memory that will make every other bath the rest of your life miserable. And there's a reason why they're doing that. And it's better to let them be dirty for a day and figure out the reason than to create a post-traumatic stress disorder by really ganging up on somebody and assaulting them, which is really what it becomes when you shower people with 4 people holding you down. It's kind of an assault just to get a body clean. Ain't worth it. Ain't worth it for any of you.
I don't know how many of you were here when I gave a lecture a month or 2 ago, but I brought up a really kind of interesting story. I think it happened the day or 2 before the lecture, why it was fresh in mind. A friend of mine, who's Dr. David Elkin, who works over at the General, was preparing a lecture in regards to Joseph Campbell, a narrative kind of style of therapy, looking at the myth and how we're all trying to live into a certain type of person. And he was preparing this lecture as he was doing the overnight shift in the ER, where a very hostile patient had been put aside in a seclusion room because he was not fit for public viewing at that time. But it was open so he could come out, but he was in there, and another patient came roaring in and started squaring off to the nursing staff. I don't know if you remember me talking about this before, but so he started squaring off to the nursing staff, and of course all the staff kind of went around and they were trying to figure out how to protect him. Well, all of a sudden, from that seclusion room, the other violent patient came out and started squaring off to the patient. So the patient turned away from the nurse, squared off to him, and they were both standing just like that, kind of corny looking, but we're going to get in this fight. And so the doc, freshly looking at this narrative kind of therapy, said, "Stop! You're a hero," to the patient who came out of the seclusion room. "You saved us all." And he went, "Oh." And then the other patient went, "Oh." That was it. No more assault. We didn't have to take him down. We didn't have to medicate him. You know, we sort of recognized this thing that was happening with this patient. He came out because he wanted to do something. I want to save this. And Dr. Elkin wisely, I don't know if I could have done this, said, "You're a hero, you did it." And he kind of said, "Okay, I've done what I came out to do." And the other person was maybe just confused at this point, kind of lowered his fist too, he didn't know who to battle. And we went on our way. So that was a very nice interaction, very much against the usual biomedical model, which says we call the deputies, we hold them down. I have to tell you, this is not publicized, but they are tasing more people in the hospital than they ever have, because there's been more assaults, because they go up against a brick wall. A patient comes in like this, the IP, institutional police, or the SF deputies who are also at the General come in and do what they know to do. They control by pain and force. So you start getting this whole culture of people walking in with mental patients with shields or with tasers drawn and ready. And it just really flies in the face of what we're talking about today. Anyway.
When I look at the world through my well-being domains, and I see people who are often either shouting or striking out at those who are trying to assist them, I tend to focus on 2 of those domains. One is autonomy and one is security. I think in the vast majority of cases, people are either being controlled or feeling a loss of choice and control about what's about to take place, and or they are not having this assistance provided in a way that makes them feel safe. They feel unsafe, and so they react the way most of us would if we were made to feel unsafe. So if you think about this, if you're either feeling unsafe or if you're feeling out of control, does bringing in authorities to force you help those 2 domains of well-being, or does it make them worse? So that shows how what makes sense to us actually has the opposite effect on the person who's confronting this kind of situation. Yeah, Mary Beth.
My question is, why isn't the word getting out there soon enough to the medical community? And I think of something like taking my husband into Kaiser, which you go through the door after you've presented your card and all this sort of thing. And the first thing they do is grab my husband, throw him on a scale, tell him to roll up his sleeve, not high enough, not high enough. And the thermometer in the ear, and I can't get them stopped.
Yeah.
I mean, it's like, whoa, back up here. Is this that critical? My husband's 100% physically fit, first of all, and it should be obvious to anybody who sees him that his blood pressure is not a problem. In fact, he was just here a week ago, and it wasn't a problem a week ago either.
It's going to be soon.
That kind of treatment, right?
Yeah, mine this way. But I mean, we're talking about the Guru Project and listening to but what is the feeling about getting it out there into the into the medical community? I mean, and drawing blood. Oh my gosh.
This is a huge industry, biomedical, pharmaceutical / advocacy organization industry that is really creating this box around this disease that has to be eradicated. instead of understanding the person who's going through a very human experience from his or her perspective. And this is a real problem. This is a problem with our conversations about what Alzheimer's is and what we need to do about it. And it comes out in the movies, it comes out in commercials, it comes out in the pharmaceutical industry, advertisements, and it's something that not just doctors but family members also buy into, because it's a societal thing. And the way we know it's societal is that even though all this talk is going on about nursing homes, it's hard, we don't have the same instruments to measure this elsewhere as we do in nursing homes. But what little data I've seen suggests to me that there are actually far more people inappropriately taking antibiotics in their own homes and assisted living than there are in nursing homes. And there's no media or government initiative to address those people. It's all about nursing homes. But there may be 250,000 people in nursing homes taking antipsychotics for dementia, and there are probably 1 million or more living in the community that we don't even pay attention to. So that shows it's a societal paradigm. It's not this model of care or that model of care. We have got to really chip away, and I agree with you. I mean, that's what we're doing. That's what the four of us and many others do in our little way, but we're little voices. Sometimes you feel like you're spitting into the ocean when you talk about this.
We're peeling away lessons that we've been taught since we were little kids in this country. I think 200 years ago, this was the primary model.
Yeah.
You know, we didn't have all these fancy, expensive drugs and different things like that a couple hundred years ago. We had, you know, being with the people and seeing where their situation is, see what the family situation is, and do what you can with what little resources you had. But now, from the time we're little, we're sort of taught what to strive for, what is happiness. You know, we got to have lots of things and have smiles on our faces every time a picture is taken. Let's all smile. You know, think about it. Well, Alzheimer's isn't like that, and most disease states aren't like that. They don't fit into what success looks like. And so we package them up, we box them up, we have other people sort of deal with it, and the medical community is no different. You know, we're a success if we get vital signs in the morning. I'm just thinking back at the ER, that's where my world is a lot. You know, we got to get the vital signs on the sheet. We got to make a note every 4 hours. Do you have to see people? I mean, I spend in the ER probably 10% of my time seeing patients and 90% of my time writing out things on paper, because of what the system dictates is what a success is for my day. You know, so doesn't that seem flipped? Doesn't it seem like how to correct that is through lectures and discussion like this? But we can do some system work. Nader's nice enough to embrace this in this system. But a lot of it does come from individuals like you all taking this message out to the next care situation you're in. A lot of it is baffling and somewhat disheartening, because we're going against a whole society crafted like this.
Right. Richard?
What if Alzheimer's wasn't a disease? What if dementia wasn't a disease? What if it just is a state that people go through as they get older? What if our brains had evolved and had settled into 30 years as a long enough life, and in 200 years it went from 30 years to 85 years? Do you think our brain is lagging behind in terms of its ability to cope with the stresses and the issues now that weren't there in the 1800s? I think so. So what if we just saw it as, you know, they say if you live to be 85, half the people are going to have symptoms of dementia. Can you call that a disease when half the population has the disease?
It's an epidemic.
Yeah, right. That's what we do. That's the word we use. Rather than address is it a disease or not, we say it's a god-awful disease now.
We have an epidemic of aging.
You know, how embarrassed will you all be 20 years from now when it turns out that this is just what happens to people when they grow older? And some people grow older and become demented, and some get cataracts, and some people have heart conditions. And there's lots of conditions that we have as we grow older. And it's because we're growing older too fast. We can't adapt to it. You know, we can exchange virtually every organ in your body now. with either a pig's or a 3D printer or your neighbor's organ, okay? But we can't exchange the brain. We don't even understand the brain like we understand your liver and all your other organs. So until we start focusing on this as a brain issue rather than is it a medical issue or is it a drug issue or how do they interact, we're never going to address this, I don't think, in a meaningful way. Eventually, we're going to have to get to the point where we have to say, all right, now we can't give them any drugs, we can't tie them up, we can't lock them in their room. God, we're going to have to go in and talk to them. That's all that's left. Why don't we start with that? And why don't we have enough faith in humanity that if we would start with that rather than have to go through all this other crap before we start talking to people? I don't know, I could cry when I hear stories that people tell about what happens to people with dementia, because I'm very empathetic with them, obviously. And I can just imagine a mind that can't express itself, but it has predispositions to feel a certain way. And we can't get rid of those predispositions in 200 years. It wants to be in control. It wants to feel good about itself. It wants to feel loved. All the things that define our humanity, that's all living in our brain somehow. And it doesn't go away simply because some of the circuits are dying or we get some plaques or tangles in our brain. That doesn't rewire our brains. That our consciousness has not changed in 200 years. But that's how we see people who have dementia.
It's why I've more and more come to see this whole thing as part of the human experience rather than looking at it as a disease state for exactly the things Richard has taught me about. And I still think Richard's theory of Alzheimer's is the most brilliant one, that maybe our brains haven't evolved fast enough to keep up with longer lifespans. You know, I certainly am in favor of finding medications that may help slow some of those changes. But here's the most challenging thing I'll throw out at you before we finish today. If we put too much focus on cure, what we're really doing underneath is we're putting a focus on fixing difference, fixing deficits, and it creates a society where you don't have value unless we can make you more like the rest of us. And is that really the place where you and I want to grow old? So we have to be careful about the balance. And right now the balance is too far toward give us more money and we'll find a pill to make this go away. And when you have an illness where the #1 risk factor is the number of years you've been alive, until we cure aging, I don't think we'll ever have a day when people don't forget more than we think is normal. And so we need to change our conversation to how do we accommodate, how do we include people whose abilities may not be different than, may not be exactly the same as the mainstream, just like we've done with people with developmental disabilities, like we've done with people, you know, from different backgrounds or different amounts of education. How do we put Alzheimer's into that bucket and start to see people the way we see difference in other ways?
Yeah, and maybe just as you're finishing up, I mean, the last 30, 40, 50 years have seen a tremendous increase in us being curious about other cultures. So now we have university classes, college classes, high school classes that talk about cross-culturalism. We are curious about how other countries and other nationalities are behaving, what they do, and so forth. So I think this is just another way of looking at difference as something that we can learn from, because we don't say the Italians are wrong because they eat too much pasta, right? Or the Chinese are this or the whatever. So can we also develop a curiosity about what that is like? And so actually look at all the difference as learning. We want to go to another country because we want to learn what do they do, and we find that nice or interesting. So what is this country called dementia or forgetfulness that we can learn from? And what purpose does it serve us in the mainstream? I mean, I think that's the only control that we have over our life is what can I learn from you? Otherwise, I just make you a problem. So rather than not making you a problem, I can actually learn something. So anyway, thank you all for coming. We have to go, but I do want you guys to take a postcard with you. There are some more events. Al and Richard are going to be here all week, and we have a nice gala event. More food. I know most of you actually only come here because of the food. I'm very clear about that. But please, there's a great gala event also, and we have a few more events going on during this week, so please join.
Are you selling books?
Oh yeah, and we are selling books. Oh, thank you so much for saying that. So everybody here has written books on this topic. Richard Taylor's written books. Al, there's also a wonderful little poem book by Dr. Patel, and we have a few books. Ed Voris wrote a book with some of us who also actually lives here, who has Forgetfulness. So there's lots of material to read on for those who are interested.
How do you explain shock treatments? I don't know about it.
I'm gonna switch that to the guy who's probably. I mean, I've been party to them, but the guy who knows the most about them is right
Beautiful.
here.
Okay, I'll let you guys.
Oh, yeah, we'll talk about that in a
Nice
moment.
action.
Thank you so much.
Thank you, everybody.
You know,